Hello everyone, this is Suyesh here, and now in this video we'll be continuing in the section of our general pharmacology, in which we'll be in the section of our general pharma we will be continuing in the section of our pharmacokinetics. So in the pharmacokinetics, as we have discussed our absorption of the drug, we have actually four parts, four processes which occurs in pharmacokinetics, and absorption, distribution, and this ADME. Okay, so absorption, distribution, and metabolism of drugs we have discussed. Now we are going to discuss the elimination of the drug or excretion of the drug. Okay, so that is the main part, how the excretion of the drug is done, that we will be discussing in this video. Okay, so the previous process was metabolism. So metabolism and excretion are the part of elimination of the drug. Okay, so excretion is different and metabolism is different. Okay, so first of all, what is the definition of excretion actually? Okay, so in excretion actually there is removal of drug and its metabolite. So this metabolite is actually the product which was formed during the metabolism, that is after the metabolism, which is now going to be excreted out through urine or feces, depends on the form of the drug. Okay, so that is the metabolite here from the body, and this process is known as drug excretion. Okay, so this is the main definition for excretion. Clear? So now what are the routes of elimination we have to discuss. The main route from which your most of the drugs are excreted out is kidney. Okay, so in kidney specifically it is excreted via urine. Okay, via urine the most of the drugs are excreted out, filter out, and then it is excreted out through the urine. Clear? And other processes, other channels can be like through lungs, exhalation of air, and through bile also, which goes in the feces, and directly from the feces also. In sweat also some drugs are released out, in saliva also through the sputum, and tears also, and in the breastfeeding mother through her milk. Okay, so from there the drug can also be excreted out. So main channel is our kidney. Clear? So we will be discussing mainly the processes which occurs during the excretion in kidney. Okay, so let's start. So for excretion, as we have discussed in the metabolism video, okay, so the aim of the metabolism was to make the drug water soluble. So it is actually, the process is called as ionized form of drug. Okay, so that will be excreted out. So main aim was to make the lipid soluble to the water soluble, that is the polar form, so that they are not reabsorbed in the renal tubule. So this line will be clear in the excretion video. Okay, so why we have to make the drug water soluble. Okay, so that is the reason that it should not reabsorb again in the systemic circulation through the renal tubules. Clear? So that was the main aim for metabolism. Now metabolism has done his work to make the drug water soluble. Now this drug, this metabolite which is water soluble will be excreted out. Clear? So this was the aim of the metabolism here. Clear? Now in kidney, as you know, there are three processes. First is glomerular filtration, second will be your tubular secretion in the proximal tubule. Okay, and in the distal and the collecting there is reabsorption of the drug. Okay, so this is a passive process and this is the active process through the channels or transporters. Okay, clear? So now if we have to discuss all these processes on this diagram, you can see this is the structural, you know that the kidney, the function and structuring in the kidney is nephron. So there is a structure of nephron. Okay, so I have written the theory here. I will just relating the concept on this diagram on the basis of examples. Okay, just understand here. Clear? So now as you know that GFR occurs in the Bowman's capsule. Okay, Bowman's capsule, glomerular filtration. So what happens is that in the Bowman's capsule, it is a different type of membrane. Okay, it is a fenestrated capillary. Fenestrated capillary you can say, or you can say the pores are present, which are not in the proximal and the distal tubular membranes. Okay, so it is a special form of membrane from which both types of drugs can cross, like lipid soluble and water soluble. Okay, so from here your lipid soluble drugs and water soluble drugs can be crossed and filtered out. Okay, with the blood. Okay, but you know that GFR is around 180 liter. Okay, 180 liter, and about 99% of the GFR is actually again reabsorbed, 99%. Okay, and around you can say 2 liter of urine is excreted out. So 99 out of 180 or 200 liter, 99% is reabsorbed through this distal tubular reabsorption, and 2 liter of urine is excreted out. So that is the concept here. So through that filtration, that filter part, the drug is also filtered out. So but here main catch is both the drugs can cross this membrane. Clear? This much. So the line which I have written here for glomerular filtration is that the free drug which are not bound to albumin. The meaning is that the small size molecules of the drug can cross, not the drugs which bind actually to plasma protein. Okay, as we have discussed in the video of distribution, the plasma protein binding basically is albumin. Okay, so that those drugs which are attached on this plasma protein can't cross this filtered membrane. So for that we have actually tubular secretion. So the drugs which are highly plasma protein binding actually are secreted through the tubular secretion, that is through active transport. Clear? We're discussing later on. So that is the main concept. It flows through the fenestrated capillary, as I have told you, into the Bowman's capsule, both water soluble and lipid soluble. So this is the main point here, can be filtered. Now the main concept I have told you, filtration is inversely proportional to ppb, plasma protein binding. Clear? So more higher the plasma protein binding of the drug, lesser the glomerular filtration rate. Clear? Now this was the concept behind the GFR, glomerular filtration of the drug. Now the drug has filtered out. Clear? Now the if we talk about the reabsorption here, now just relate this filtration and the reabsorption. Now as I have told you, out of 200 liter of GFR, 99% is again reabsorbed through this tubular reabsorption, that is through distal convoluted tubules through here. So reabsorption of the drug will be done from here. So just consider, here is your systemic circulation, that is the blood. So this drug which is filtered out, or the GFR, the blood which is filtered out, blood will be again reabsorbed in the systemic circulation. So this is actually your systemic circulation. So in this again the drug will be reabsorbed, 99% of the GFR. Okay, so I have written 99% of GFR will be reabsorbed, and actually what happens here is that lipid soluble drugs which are filtered through GFR will be again reabsorbed. So main catch is that the drugs which are lipid soluble, the main of the metabolism aim was to make the drug water soluble, so it will be easily excreted out, it will not reabsorb through tubular reabsorption. But drugs which are lipid soluble, which are also crossed in the through the glomerular membrane in the Bowman's capsule, they will again reabsorb. Okay, so that it can cause toxicity also, drug toxicity, because the drug accumulation will be increased in the systemic circulation. So that is the main catch here. Clear? So lipid soluble drugs are reabsorbed, but water soluble is excreted out. So that was the aim of our metabolism, to make the drug water soluble here, so that it is not reabsorbed. So in distal tubule, this membrane is not fenestrated type, so only lipid soluble will be crossing each other. Okay, lipid soluble drugs will be, because this is lipid bilayer membrane, so it will be only allow the lipid soluble drugs to cross again in the systemic circulation. Clear this much? So this was the main catch. So ionized drug are excreted out, that is water soluble. Clear? Now what we have to do to make the drug, that is the toxicity does not happen, or the duration of action is not increased, how this lipid solubility will be changed. Okay, so for that we actually do, if the drug is weakly acidic drug, just consider, if the drug is weakly acidic, if the drug is a strong acidic or strong basic, it will be ionized automatically in that, and it will become water soluble, ionizes polar, and it will be excreted out. But the drug which are weakly acidic drugs, they will be in the unionized form in the nephron, okay, in the distal part, so they will be reabsorbed. For that what we actually do, so they remain in unionized form like barbiturates and aspirin. Clear? And just consider they remain in the acidic urine. Okay, so they are weakly acidic drug and the urine is acidic, so they will not react and they will remain in unionized form, that is non-polar. Clear? So what we do is that they are reabsorbed into the circulation. Okay, so they can lead to toxicity. Now we make the pH of the urine alkaline, okay, by adding sodium bicarbonate. Clear? And drug is now ionized, that is become water soluble, and it is excreted out. Clear? So this happens with a weakly acidic drug, we make the urine alkaline, and the same with the weakly basic drugs. Okay, weakly basic drugs like morphine and amphetamine, this ene, you just remember the ending with ene are actually basic drugs. The drugs which are ending with ene, INE, are basic drugs. Clear? So the urine is basic, so they will again like acidic, they will be also not unionized, and they will be reabsorbed, can also lead to toxicity. So in that case we make the pH of the urine acidic by adding NH4Cl. Clear? And the drug is now ionized, that is water soluble, and it is excreted out. So that is the main concept behind tubular reabsorption, what we do to make the drug water soluble, to make the drug water soluble, so that it can easily excreted out and there is no such drug toxicity. Clear? So this was the main concept behind the tubular reabsorption, distal tubular reabsorption. It is a passive process. Clear? Now the third process which we have is active tubular secretion. Clear? So this occurs in the proximal, that is the PCT part here. Okay, so PCT part. So here some drugs are actually directly from the systemic circulation, some drugs are directly absorbed through this PCT, and here there are some transporters. Okay, so drug will be absorbed through this channels, you can say, or transporter, you can say. So this is an active process. Clear? That is why it is an active process. So it is actually for the drugs which are highly plasma protein binded, the drugs which have high affinity for plasma protein binding capacity. Clear? So those drugs are actually excreted through the tubular secretion. So just will be just reading the line here. It is a carrier mediated active transport, as I have told you, and drug is secreted from blood into the urine. As I have told you, this is systemic circulation, that is the blood, and now it will secreted into nephron, that is the urine. And there are two transporter, one is for acidic drugs, okay, anion, and one is for basic drug, cation. Clear? So these two transporter are present and they are saturable. I am telling you the meaning for saturable, and it is important for drug with high plasma protein binding, as I have told you. Clear? So now what happens is that only one drug, the saturable meaning is that if two drugs are there and they both are acidic drugs, only one drug can pass at one time. Okay, so the drug which has higher affinity for this transporter will only cross. Okay, so just take an example here, like penicillin. Penicillin is an acidic drug, okay, and it is short acting. Just consider it works for around 3 to 4 hours normally. Okay, and if the penicillin is given with probenecid, as in this drug is used for gout, arthritis, okay, gout and arthritis, and it is actually for the increases the level of uric acid in urine. Okay, so if the penicillin is given with probenecid, the combination, so what does this probenecid do? So in the PCT, just consider this is your PCT and this is the transporter, okay, anionic transporter. Now this is your aspirin and this is your probenecid. Now probenecid will cross firstly, so there will be a competition between probenecid and penicillin. So probenecid will not allow penicillin to cross the this transporter. Okay, so now penicillin will stay in the systemic circulation. Now the action of the penicillin will be increased. So that is the work of the probenecid, and this probenecid also increases for cephalosporins also, penicillin category drugs also, and cephalosporin category drugs also is also a competitive inhibition and increases the duration for both of these drugs. Okay, so that is why now penicillin becomes a long acting drug after adding probenecid, because penicillin has a high plasma protein binding and it is excreted through tubular secretion. Clear? So these are the three processes here, and one more this formula here, rate of renal excretion, by relating all these three processes, the rate of filtration plus rate of secretion minus rate of reabsorption. Okay, so rate of reabsorption actually decreases your excretion because the drug will be again reabsorbed, but rate of filtration and rate of secretion will increase. So that is why if the drug is some percentage of drug is reabsorbed, then we will subtract that amount and add the filtration and secretion rate, and then the rate will come how much drug is excreted through the urine. Okay, so just consider. Okay, so now I will be telling this this concept with one example here. So just consider 100 mg of drug was glomerular filtration of the drug was done. Okay, and renal clearance of this drug was 80 mg. Okay, so the meaning is that 100 mg was filtered out, but only 80 mg was cleared out. So now some of the drugs are reabsorbed. So meaning is that the decrease in the renal excretion is due to the presence of tubular reabsorption. So if the GFR, just consider if the renal clearance is less than GFR, okay, then tubular reabsorption is must. Okay, but tubular secretion may or may not be present. Okay, so just take an example. If 100 mg was GFR and 80 mg was renal clearance, and 20 mg just here, the basic, this is the first scenario. If the secretion was also present, just consider 50 mg was secreted, tubular secretion of the 50 mg of drug was tubular secretion was done. Now the total drug we have 150 mg which is secreted out, and we have the renal clearance 80 mg. Now this tubular reabsorption will be how much? 70 mg. Okay, 70 mg. So that is the main concept, is that if the renal clearance is less than GFR, then tubular reabsorption is must, but tubular secretion may or may not be present. And if the reverse is happening, that is the renal clearance is more than GFR, just take an example of this. 100 mg was GFR, glomerular filter of drug, and now 150 mg was renal clearance. Okay. So in this case, what will happen? What will happen? In this case, tubular secretion is must, because the total GFR is 100 mg. But the secretion is must, it will be present, but tubular reabsorption may or may not be present, because 50 mg can be secreted out, so total will be 150 mg. But another case can also happen, like 70 mg was tubular secretion was done, but 20 mg was reabsorbed, then again the total will be 150 mg. So total secretion was 170 mg, but out of 170, 20 mg was reabsorbed. This can also happen, and only tubular secretion can also present, like 100 mg was glomerular filtered and 50 mg was tubular secretion. The total we have 150 mg of renal clearance. So both the scenario can present. Okay, it can be less, but the main catch is that if the less, then tubular reabsorption is must. If more, then tubular secretion is must. So this was the drug excretion. So I think it is clear. We are done with the pharmacokinetics concept. Then next video will be move on to the pharmacodynamics. Okay, so do like, share and subscribe the channel.